Dr. Raed Awaisheh, I think he's well known to all of you, interventional cardiologist in Amman here. He will talk about peri-procedural anticoagulation therapy in patients undergoing PCI. Welcome, Dr. Raed.
Thank you very much, Dr. Ibrahim. Thank you very much for everyone present in this room. Thank you for our guests. It is an honor for us actually to have all of you here until this moment. I would like, in behalf of Boehringer, thank you for sponsoring this talk. And I don't have, for my disclosure, I don't have any interest, financial interest with this talk. It is about the very important topic, which is the anticoagulation in patients going for intervention. When you come to the atrial fibrillation, actually it is a big burden to have atrial fibrillation. For the last 10 years or 20 years, in 1990, there was about 7 million patients they have atrial fibrillation, and this number increased to 11 million in 2013, and the number is able to increase more and more. And when we come to the population of age more than 40, we have 1 in each 4 people, he has atrial fibrillation. So this is very high percent to have 25% of the population more than 40-year-old to have atrial fibrillation. And as we know, atrial fibrillation of high risk to cause a stroke, 5 times more than a patient who doesn't have atrial fibrillation. And when we come to the risk factors for atrial fibrillation, they are a lot. Some of them we cannot change, but most of them we can change, and most of them, they are very easily to be avoided or modified or recovered. So to avoid atrial fibrillation is the main station of a treatment. When we come to the latest classification of atrial fibrillation, any patient with atrial fibrillation comes to you for the first time. This is first diagnosed atrial fibrillation. When you have a patient with atrial fibrillation within 7 days reverted spontaneously, this is paroxysmal atrial fibrillation. When the atrial fibrillation persists more than 7 days and needed electrical or mechanical conversion, this is persistent atrial fibrillation. And long-standing persistent atrial fibrillation when it exceeds 12 months, and the intention of the patient and the intention of the physician to treat and revert this atrial fibrillation and to achieve sinus rhythm, not just rate control. And this is the difference between it and the permanent atrial fibrillation, where there is an agreement between the patient and the physician to have a rate control instead of rhythm control. When we come to the IHRA symptoms scale, it is very important actually for atrial fibrillation to interfere with the daily activity or not to interfere with the daily activity. If it doesn't interfere with any activity, this is score 1, where there is no symptoms, and score 2, where there is symptoms but doesn't interfere that much with the daily activity. Once it starts to interfere with the daily activity, this is score 3, where it is severe, and when it is disabling the patient from doing his daily activity, this is really disabling, and it is of a score 4. It is very important for us to find really the tiny line between increasing bleeding and increasing risk of thrombosis. That's why we have this complex scoring system, which is not any more complex because we have seen it many times, and already all the guidelines and everybody is using this in treating atrial fibrillation. We need to treat the patient with atrial fibrillation. How strong shall we treat him? It is the tiny line between hemorrhage and the thrombosis, and this score actually is to help. Sorry. So the guidelines recommendation for treating the patients with atrial fibrillation, definitely NWAC now is a class 1A recommended for non-valvular atrial fibrillation, and the exceptions, as we know, when we have mechanical valve or you have moderate to severe mitral stenosis. Also, it is of class 1A not to treat with anticoagulation for patients who have a low CHAD score. And it is very important to remember that men with CHAD score of 0, women of CHAD score of 1, no need to anticoagulate. And when you have higher CHAD score than this, it is a class 1A indication to treat and to give NWAC. For the last 10 years, and even before that, the only treatment, or before 10 years, or before the decade that we are, the light decade, the only treatment was aspirin and warfarin. And simply, aspirin was not effective, and warfarin, or vitamin K antagonists, were dangerous, not safe, increasing the bleeding, difficult to control, and not easy to manage the INR, and difficult to have the control. And that's why you have still in most of the countries, half the patients with the atrial fibrillation, they don't have treatment, and if they are on treatment, they are not controlled. So we have really a big problem with the atrial fibrillation. That's why we have the NWAC. When we come to the NWAC and compare them, maybe we don't have that much of head-to-head trials, but now they are available. Some of them, they are available. And when we come back to the criteria of the NWAC for the absorption and metabolism, the most important points that the clearance, most of the clearance for the rivaroxaban and apixaban is renal, while it is partially for dabigatran. And when we come to the food affects rivaroxaban, while it doesn't affect the others. So it is advisable to give rivaroxaban after 2 hours from the meal minimum. And the important thing is that the apixaban and rivaroxaban are not dialysable, so you need to adjust the dose when you have patients in dialysis, while it is partially dialysable for the dabigatran. When we come to the dose adjustment, you need to do dose adjustment in some cases, but it is the standard dose for dabigatran is 150 twice daily, for rivaroxaban 20 milligram once daily, and apixaban 5 milligram twice daily. In exceptional cases, this is exceptional to give 110 milligram BID in patients who are of age more than 80 years old, or patients already on verapamil, or the patient has increased bleeding risk. While for rivaroxaban, the exceptional is to give 15 milligram once daily when you have creatinine clearance between 15 and 49 ml per minute. And for apixaban, when you have 2 out of 3, when you have age more than 80, and body weight of less than 60, and serum creatinine of more than 1.5 milligram per deciliter. Now, when we come to the evidence of relay, you know that we have this study for the more than 1 decade now, and it is comparing warfarin to the 2 doses of dabigatran. And the primary outcome is the stroke or systemic embolization. And when we come to the standard dose of 150 milligram twice daily of dabigatran in comparison to warfarin, you can see significantly that it reduces the risk of stroke, systemic embolization, cardiovascular mortality, major bleeding, and ischemic and intracranial hemorrhage. Maybe the same as for the major GI bleeding, same as warfarin. While when we go down to 110, which is the exceptional, and in 110, you still have the advantage of reducing the major bleeding and intracranial hemorrhage, and this is, in general, the advantage of NWAC in top of warfarin. This is very important, actually, for ischemic stroke in comparison. You come to the 3 major or 3 well-known NWACs in the market, and we are using them, all of them, the 3 of them. We should remember that for the dabigatran, it is the only one which, in comparison to warfarin, reduces the risk of ischemic stroke. Here we are saying ischemic stroke, not embolic stroke, because embolic stroke reduced by all, but for ischemic stroke, dabigatran is the only one reduced the risk relative reduction of 25% in comparison to warfarin, while the others, they don't do. And when we come to the hemorrhagic stroke, all of them, they do perfectly well. What I like about the dabigatran in the studies and the conclusion of the studies, there is no extrapolation and there is no underestimation of the effect by the statistical or the sub-analysis or the subgroup, while you have in the relay study, you have an equal division of the of the patients in the three groups in equal number, completely different than in the other studies like rocket atrial fibrillation for rivaroxaban, or Aristol for apixaban, or Engage AF for edoxaban, where you have the small dose, the exceptional dose is really of a small number of patients. So maybe there is some extrapolation and some statistical concerns in these situations. Now when we come to the real practice, and the real practice where we have the atrial fibrillation and patients on the dabigatran in comparison to rivaroxaban, and in these studies, this is a study sponsored by Medicare, FDA, it is not by any of the companies, and it showed that it is safer to give dabigatran in the concerns of decreasing the intracranial hemorrhage, the major extracranial bleeding events, and for gastrointestinal bleeding, and all hospitalization for bleeding. So in favor of dabigatran actually to reduce the bleeding, and the bleeding increases in different aspects with rivaroxaban in this study. So the simplest conclusion of this is to go with the safer drug. So by this study, the dabigatran showed that it is safer, maybe with the same effect, but safer. In these meta-analysis and multiple studies, comparing for the major bleeding, comparing dabigatran to warfarin, most of the studies, 80% of the studies, they are in preference of dabigatran. In comparison, dabigatran to rivaroxaban, 77% of the studies in favor of dabigatran, and for intracranial hemorrhage, in comparison to apixaban, it is similar in 78% of the analysis, while in 22% of the analysis there is a significant better for dabigatran in comparison to apixaban. So in conclusion, the dabigatran is a safe medication. When we come to this case study, I think I have 1 minute to go, so I go very rapid. This patient with multiple risk factors, and he's going for PCI. This is very important actually, where we have usually there is an agreement between the European and the American guidelines. While this is the 22 ASC guidelines in comparison to 2021 American guidelines, when the patient is going for PCI in the European, you don't need to stop the warfarin, and you need to give the anticoagulation if you have INR of less than 2.5. And if the patient is in WAC, no need to defer the PCI, and you go with the PCI and you give the anticoagulation. While for the American, they do the opposite. They interrupt, and they advise to interrupt and wait for the INR to go below 2 when you go for radial approach, and you wait for the INR to go below 1.5 to go for femoral approach. And if your patient's in WAC, you need to interrupt and defer for doing the PCI. Am I done? This is I think this is the most important one. So go with the wait for 24 hours or wait for 48 hours. The last point, if you allow for me just for 15 seconds, is to stress on the importance of having the antidote, the idarucizumab, where you have it only for the dabigatran, and it is only for dabigatran, it is not available for the other anticoagulants. So for the sake of time, this is my conclusion. You go with dabigatran now. It is the treatment for approved treatment for DVT and PE, and prevention of DVT and PE, and for patients going for orthopedic surgery and to prevent stroke, and decreasing the risk of hemorrhage. Thank you very much.
Okay. Thank you, Raed.
We'll keep the question till the end of the second lecture.
Dr. Marwan.
Dr. Marwan, it's time for you. Dr. Marwan Nmri is a well-known cardiologist. He was the head of cardiovascular department in the Royal Medical Services, and now he joins his private practice, and he will talk about He will talk about the metabolic approach, early start in the angina universe.
Right. Good afternoon, ladies and gentlemen. It's a pleasure to be here with you. And I'll try to talk a little bit about medical therapy, which is a well-known topic for you all in the treatment of angina, but highlighting some changes in the guidelines of the European Society of Cardiology. I'm sure it's interesting to hear that, because the trend is just only to try to go for treating major epicardial. Is it okay, مسموع?
Close to the speaker, please.
مسموع ولا مش مسموع؟
Yeah.
طب هيك. It's okay. All we know that the mechanism of angina pectoris is a mismatch between the oxygen demand and the coronary blood flow. This is a fact for all of us. The pathogenesis to all of us, as I said, is we assume that our patient is having a stenosis of a major epicardial coronary vessel, and opening that vessel by angioplasty would solve the problem, reduce the angina, and trying to prevent cardiovascular events. But what am I going to try to tell you, that angina is not just only about the disease of the major coronaries. There are so many other factors contributing to angina. So if just only allow me to remind you that coronary trauma is the core, it can lead to unstable angina, to acute ST elevation myocardial infarction, non-ST elevation myocardial infarction, and even in patients who are going angioplasty, it can recur and it can affect the grafts or even the stents itself. But I'm trying to concentrate on the cardiometabolic disease and other component which is important in the pathophysiology of the phenomenon, which is the vasospastic angina. So the mechanisms of myocardial ischemia is not just only coronary stenosis, which is high up there. في pointer في هذا ولا كيف؟ هذا عليه pointer؟ شباب I'm sorry شباب, هذا عليه pointer؟ وين pointers؟ ما في pointer؟ ما في pointer, okay. No problem. So the mechanism of myocardial ischemia is so different. It's a multifactorial. It's a coronary stenosis, all right? It's a platelet aggregation and coagulation. It's inflammation. It's primary metabolic abnormality, myocardial bridging or vascular spasm. And the most important thing is the microvascular dysfunction. So in a study where they, back in the year 2010, it was published in the New England Journal of Medicine that more than 2 million people were studied. Just only 38% of the patients with angina had an obstructive coronary artery disease. And the others, they have, which 2/3 of our patients have no obstruction. So it's not okay just only to think of opening a coronary with an angioplasty. What about the others? What about the other mechanisms? What do we do to alleviate their symptoms and try to prevent future cardiovascular events? So we talk about a microvascular angina now, all right? This slide is very important. 1/3 is just only which is appearing is the epicardial vessels, but 2/3 they have a microvascular disease. This illustration is an excellent slide, I think, because the three mechanisms, which is the stenosis of the major epicardial vessels, the coronaries, all right, atherosclerosis, vasospastic disease, and the microvascular dysfunction. Remember that all three mechanisms can overlap, they can coexist. So treating just only the major vessels by angioplasty would not solve completely the problem, all right? This slide also demonstrates what I have already said, all right? So there are other components, the microvascular angina and the vasospastic element is very important. It's not just only the major vessels. The European Society of Cardiology, always they are updating their guidelines. This is just only to compare between the guidelines in the year 2013 and the year 2019. We were talking about coronary disease, and in the year 2019, they started talking about chronic coronary syndromes. This is important. And as a reminder, just only 15% of patients with angina, they present with typical angina. So how do the others present? The other thing which changed during the past years is that any patient diagnosed with angina less than 12 months is considered a newly diagnosed patient. And these patients should be treated as such. They should be evaluated every 3 months, 4 times a year, for assessment of the treatment you are giving and for risk stratification and planning for the future therapeutic plan. All right? What is our aim of treatment angina patients? We need to stop their anginal pain. We need to reduce their symptoms or even exercise-induced ischemia. And ultimately, we need to reduce or prevent cardiovascular events. What we call the optimal medical therapy. Optimal medical therapy is 2 components. One of them is dependent upon the treating physician. What are the type of medications he prescribes to the patient? When he does prescribe, when he switches from first line treatment to second line, or when he add another agent. And the other component is the lifestyle modification, which depends upon the patient. So this is an important also slide, just only to highlight what I said. Medical treatment of symptomatic patients requires 1 or more drugs of angina relief in association with drugs for prevention, for prevention of major cardiovascular events, all right? It is recommended that patients are educated about their risk factor. This is the lifestyle modification when you tell your patient. Unfortunately, in Jordan, our patients don't stop smoking, they do not reduce weight, they do not walk, even they do not swim. All right? So these are important in conjunction with the medications you give. What do you need to achieve giving medical therapy to your patient? You need to start early, you need to see a rapid response, at least within 2 to 4 weeks' time from the initiation of the treatment. And this is a recommendation from the European Society of Cardiology. And then every patient is different from the other. You have to individualize your treatment. This is what we call a tailored procedure or tailored medical therapy for each patient. All right? So, in the guidelines of 2019, the optimal anti-anginal medical therapy is defined as treatment that satisfactorily controls symptoms, all right, with maximal patient adherence and minimal adverse events. Patients are tailored. Tailored approach is important. Every patient is different from the other. And fast angina relief is important. We stress on that within 2 to 4 weeks' time from initiation of the anti-anginal treatment. There are first line, second line, and third line medications. We will talk more on the next slides. What changed in the guidelines from the year 2013 to year 2019? If you look to the first one, exercise ECG, how to evaluate your patient. What is the aim of evaluating your patient 4 times a year? Evaluation of your treatment and evaluation of the risk assessment of your patient. So exercise ECG was done to diagnose stable coronary disease in patients with intermediate pre-test probability. But nowadays, exercise test is usually done for risk assessment and to rule out or rule in coronary artery disease. The most important thing which I want to stress is that trimetazidine, which was considered in the year 2013 as a class 2B, nowadays is considered class 2A. All right? So trimetazidine is upgraded from less beneficial to more beneficial in the medical treatment of patients with angina. The important thing is that this drug has no hemodynamic effect. It does not lower blood pressure, it does not deal with the heart rate. So it's good to use it in patients with low blood pressure, and it should be used in patients with a low heart rate. Remember that first-line treatment is aspirin, ACE inhibitors, beta blockers, all right? And most of our patients are receiving a long-acting nitrates. When you have a low heart rate and your patient is not controlled, it's not okay just only to satisfy yourself by opening the vessel by stent and your patient is not controlled angina-wise. So you have to add something. Add trimetazidine with no fear because it has no hemodynamic effect. It has nothing to do with the blood pressure and the low heart rate. So it does not cause bradycardia or hypertension. So angina, how can it express itself? First of all, angina, which can be how to differentiate between the mechanism or what is to speculate about that. Angina, which is triggered by exercise at a predictable threshold and relieved by a sublingual nitrates, is strongly suggestive of epicardial stenosis, which we know that it is around 38% just only from all our patients. Angina, which is triggered by exercise at a variable thresholds, okay, and sometimes at rest, poorly responsive to sublingual nitrates, is most likely related to a microvascular origin. So this mechanism or pathophysiological mechanism of angina is important. We have to address it. Angina occurring predominantly at rest, relieved by sublingual nitrates, is likely due to coronary vasospasm. So the vasospastic element is there. How to relieve angina symptoms? Recently diagnosed patients who are diagnosed less than 12 months should be evaluated, as I said, 4 times a year, every 3 months. We have to give them medications to relieve their symptoms as fast as 2 to 4 weeks time, and more than one anti-anginal drug is recommended. Patients should be tailored. Every patient should have his personalized treatment, not one size fits all right? Of course, we don't forget that revascularization is helpful in alleviating symptoms and reducing or preventing cardiovascular events. What about the combination therapy? Beta blockers, nitrates, dihydropyridines, diltiazem, verapamil. There are some precautions. There are certain medications where you cannot combine. They are dangerous, like which are in the red. Okay, so beta blockers, verapamil, and diltiazem, sometimes they are dangerous and you have to be very cautious. Regarding ivabradine, which is the procuralan, this is an important drug where we use and we add in patients who, despite beta blocker therapy, they continue to have tachycardia or a heart rate above 70. It's a benign drug. It's given only to reduce heart rate, and the reduction, I don't know, you are delayed and I'm delayed. Should happen. So reduction of heart rate is very important. Why? Because all we know physiologically that coronaries do not fill during systole. The filling of coronaries take place during diastole. So whenever you have a fast heart rate, the diastolic time is short, and then the heart cannot feed itself properly to accommodate, all right? Trimetazidine can be added anytime, irrespective of any comorbidities or others. Let me skip some slides here, all right? This is important because it stresses the mechanism of action of trimetazidine. Trimetazidine, the best known mechanism of action is the inhibition of the free fatty acid oxidation, so providing energy without increasing the demand for oxygen. And on the other hand, it inhibits the glucose oxidation and promotes the cells of the myocardium to utilize glucose, all right? When you combine trimetazidine with other anti-anginal therapy, what do you achieve? You reduce the mean weekly number of anginal attacks, and also you decrease the number of usage of sublingual nitrates. This slide is important. Why? Because trimetazidine, when it is added, it's an add-on treatment. When it is added to beta blockers or other medications, the most and the biggest benefit is achieved when it is added early, immediately after beta blockers. It reduces the number of angina per week by more than 77%, all right? And this is, so in patients also with diabetes, it reduces the ischemic burden and the episodes of silent myocardial ischemia. Comparing to placebo, it's very significant. This is just only to stress that in considering microvascular disease, trimetazidine, if you compare after weeks of treatment, it will reduce it will increase the time of exercise. It will increase the time to develop an ST segment depression 1 millimeter or more on treadmill, and the total exercise time is increased significantly. So this is important. All right. The long-term treatment with the trimetazidine, after 6 months of treatment, there is a reduction by 82% of what I told you, the number of attacks of angina per week and the number of nitrates consumed by the patient. Also, there is an improvement in the walking distance. If a patient can just only walk around 350 meters at start, when you add trimetazidine, after 6 months' time, he would be able to walk double the distance. And this drug is of proven efficacy in other conditions, whatever comorbidities is there, in patients with diabetes, in patients with left ventricular dysfunction, in patients even with overt heart failure, in patients after revascularization, even percutaneously or after CABG surgery, and in patients with ischemia with no obstructive coronary artery disease, and most importantly, in metabolic vascular disease. I'm sorry if I'm delayed, but Usama شوي هيك, just only this to stress that the guidelines in the year 2013, trimetazidine was a class 2B. Nowadays it's a class 2A. Even the other guidelines, it was published in the circulation that trimetazidine has all these. In conclusion, the angina is not a disease, it's a syndrome. It's a multifactorial. There are so many elements, not just only the stenosis of the major epicardial vessels. There is a microvascular disease, there is a vasospastic disease, okay? Only 15% of our patients, they present with typical angina. The others have other symptoms. Every patient who is diagnosed with angina less than 12 months is a newly diagnosed patient, and he should be assessed 4 times a year, every 3 months. Why? To assess the treatment you are giving and to assess his risk of developing future further myocardial events, all right? You need to personalize your treatment to every patient. It's not a one-size-fits-all, all right? And trimetazidine was upgraded, as I told you, from class 2B to class 2A, and the recommendation is to start as early as possible, start immediately after beta blockers. And remember, it's not okay just only to concentrate on angioplasty, discharging your patients with no optimal medical therapy, and after 1 month, if he comes back to you complaining of angina, you repeat your angiography or you repeat your angioplasty, and this is not okay. So I'm advocating medical therapy, optimal medical therapy. There are drugs to add on, all right, and reassess your patient, and always, always, medical therapy is superior until there is a major vessel which is considered decent and can alleviate the symptoms of patients. In addition to these drugs can be used. Thank you very much indeed, and I'm sorry, Dr. Ryan.
Thank you, Dr. Marwan. We apologize for the delay due to the technical issues. We can take a couple of questions, so we give the floor for our colleagues to proceed.
Thank you, Dr. Marwan, for a nice presentation. First question. At what percentage in your experience, you believe that this metabolic treatment will relieve angina?
At what?
At what percentage?
2/3 of our patients, they have other factor causing angina than major stenosis of a major vessel. So 2/3 of our patients. And if you remember, I told you, these factors, because it's a multifactorial disease, it's now a syndrome, they could coexist together. So when you open a major vessel, which is rightly done, but your patient is not relieved, is not satisfied, his angina is not disappeared, you have to think of the other elements. So if you add trimethazidine as early as possible, you could achieve a major reduction in his angina attacks per week. You could achieve a better improvement of his exercise tolerance and the distance he can walk. So start as early as possible and reassess your treatment after 3 months, all right? And don't forget that any patient new to you is a newly diagnosed. So the first 12 months are important. Every 3 months you have to reassess, okay?
Second question. After revascularization with CABG or VCI, duration of trimethazidine?
Duration of therapy?
Of therapy.
For this reason, we stress on re-evaluating patients every 3 months to assess your treatment strategy. If trimethazidine is not bringing you the optimal results you want, you can discard it. You can use other agents, all right? But if he's tolerating that, studies after 6 months to 1 year, they showed a significant improvement on all parameters I mentioned. Is it okay to leave him forever? It's not. If your patient is satisfied with treatment, after 3 months of your intervention, if he's free of pain, you could stop it. I stop it after 3 months.
Thank you very much.
Sorry, my question is to Dr. Raed Awaisheh.
أنا خلصت يا اسمك ولا أظل؟
I have a question for Dr. Marwan.
خليه يسأل رائد بده يسأل ولا تسألني أول؟
عجل.
اسألني.
Dr. Raed? Dr. Raed is not here.
So,
عبين ما يجي رائد.
Okay, Dr. Shokat, you can go.
Okay, Dr. Marwan, if you have, you need to add on, and you have the option of adding trimethazidine and ranulazine, which one you choosing? Yes, in your practice.
You know, in my practice, because trimethazidine is cheaper in Jordan, and the cost is very important to our patients. Ranulazine is well known from years and years, and trimethazidine, just only to remind you, it was approved in France back in 1978, but in the Jordanian market, it's cheaper, it is effective. Sometimes it gives you the results you want. So I start with it, honestly. And the cost is very important. And you know, our general hospitals, they cannot provide you with this medicine.
Yes, but in terms,
am I right or not?
In terms of data, there is one study, they involved in Pakistan a small number of patients, and they compared between trimethazidine and ranulazine. They found ranulazine is more effective in reducing angina by 67% versus 33% in
Let
angina
me just
patients.
only here, time out. You do not depend on these studies. It's an observational, just only from one country. You depend on guidelines, all right? On guidelines, both drugs are mentioned. Whenever you can afford that, you add it. But if you add trimethazine alone, you are the winner, all right? Do we use the other agents in Jordan? Yes, we use, but not in all patients who can tolerate. Only patients who can afford that, all right? But please don't quote just only one study, a small study from one country. Depend always on guidelines. Guidelines are clear and you will not fall out. And any patient with angina, if you follow the ABCs, A is aspirin and ACE inhibitor, B is beta blocker, C is cholesterol control, D is dieting, E is exercising, you will not fall out. You are treating your patient well, all right? This is a fact.
The question for the panelists. So, Dr. Raed discussed very important subject, was it the NOAC. We are daily using these drugs. And till now, the guideline does not discriminate which to prescribe. So my question is, what's your concern when you are prescribing the NOAC, the efficacy or the safety of a drug? And according to that, what is the best NOAC?
Dr. Raed, I think this depends on safety. This depends on safety and multifactorial and renal function or evidence of GI problem. I think this elderly patient, and not depend which one is the best than others.
So the safety is very important in the field of the anticoagulation. You are agree with me? More than the efficacy. Because when the patient develops bleeding, he will blame you. But when he develops thrombosis, he will blame his characteristic. Isn't it true? So you are agree that the safety is more important.
The safety is important than efficacy.
Are we agree?
Yeah, and
safety is more important than efficacy?
No, I think
they are all
one is better than other.
I think you have to consider both the safety and efficacy. All of them prove they are efficacious in the treatment of AF, non-valvular lesions, AFib. Okay?
But there is superior drug and there is no inferior drug.
There are minor differences between all of them, okay? So you have to tailor your therapy according to the age of the patient, the weight of the patient, and the condition, if you have GI bleed or not, and then you select your NOAC. Nobody can answer you that question, which is the better?
Don't you think that the safest is the better?
There is no head-to-head study.
Till now.
Last NOAC guideline say no one is better than other. Just the safety is important. Selection of the drugs according to the patient criteria. Yeah. Renal function, elderly, evidence of GI problem. This is important because even this mentioned, there is no one is better than other.
So we have to individualize NOAC and not regiment them.
Did you get the question?
So we have to individualize according to the patient characteristic rather than regiment them.
Yes, according to the patient characters.
I am asking this for discussion. This is a very important subject of our daily practice.
Yes. Yeah. As I said, you have to tailor your therapy according to the patient. You have to, it is multifactorial. Okay. And all are efficacious. All are safe. However, some have better or less GI bleed than the others. Some have, you have to consider the weight. Some you have to consider the age. So you have to select your patient according to the case.
Excuse me, we have to stop. Thank you very much for everybody.
Thank you very much, everybody.